A very good morning to all of you. So I am Dr. Diksha Pandey and you are watching Urogynecology for Beginners. For a long time we have not done any case discussion. So after a long gap, today we are going to do the same. It's an interesting case, and to present that case, I have a very interesting person with me, and you know her actually. So Ananya, would you like to introduce yourself?
Hello everyone, I'm Ananya Jha. I'm third year OBG resident at Kasturba Hospital, Manipal, and I'm here with Diksha ma'am today to discuss a very interesting case.
Okay, so if you are ready, can we start?
Yes, ma'am.
Yes.
So we got a case of a 16-year-old student who was referred to our hospital with complaint of pain abdomen since 3 days and difficulty in passing urine since 3 days, following which she had consulted a local clinic, ma'am. They had done scan for her there and they had referred to our hospital with the diagnosis of endometriotic cyst on the left side. So when she came here and on asking further history, she told us that since the last 4 months, she had recurrent episodes of UTI on and off, which was treated with antibiotics at local clinic. Following which, since the last 3 days, her pain abdomen increased and she had difficulty in passing urine also, for which she had to go to that local clinic now.
And there an ultrasound was done and she was found to have an endometriotic cyst. And how big was that?
It was around, they had reported around 12 into 10 centimeter.
Okay, 12 into 10 centimeter, that means a big cyst for a 16-year-old girl was found out. Okay, then what happened?
Then we further asked history and
Okay, history you have asked.
Yes.
So do you want to, has she attained menarche?
She was 16 years old and she had attained menarche 4 years back. Following which she gave history of regular cycles, 30 days with 4 to 5 days of bleeding, and she used normal 2 to 3 pads per day, and she did not give any history of dysmenorrhea.
Okay, no dysmenorrhea. Okay, this is interesting. So there are some things we should see. This is the thing where all of us can go wrong, but there are some lessons to be learned from this case. So this is, what is your opinion, Ananya, that 4 years patient is menstruating and she is having a big endometriotic cyst? Though we have seen cases like this, I have operated a 20 centimeter cyst for a 19-year-old girl, but these are like recently, very recently, and some other young patient. But once the patient has started menstruating for 2 to 3 or 4 years, it is not that likely that she will have developed a endometriotic cyst. And what is the other thing which is going against?
Also, she did not give any history of dysmenorrhea.
Yes.
No dysmenorrhea during cycle, post cycle, no history of dysmenorrhea.
Okay. So this kind of endometriotic cyst in a young girl, should you think something else?
So we had to...
yes, we have to... suppose we know that it is an ovarian tumor. Okay. Young girls, are they prone to some kind of ovarian tumors at this age?
Germ cell tumors can be seen, ma'am.
We have to be very careful. We should do tumor markers. We should do further investigations, because the look on ultrasound of an ovarian cyst, as our experience has increased, we have realized that it can be very, very misguiding. A torsion of ovarian cyst came out as gist. It would have happened many times with you also. And then sometimes it has happened that we thought it was a benign ovarian tumor, clear, it has come out as yolk sac tumor. So it's not just the ultrasound. The message what I want to give here is that just based on ultrasound diagnosis, we should not jump onto any conclusion. We have to think about the case, revisit the history, examine, if necessary, again re-examine, and then do further investigation as per as the requirement of that case. Okay. So tell me one thing, did you examine this patient?
We examined her, ma'am.
No, when the patient came to OPD, what did we do first? Did we do ultrasound or do we examine?
When she came to our OPD, she was directly referred to the ultrasound room, ma'am.
So I think, Ananya, this was not wrong, because okay, medical sciences that you have to take history, you have to do examination, then only you should do investigation. But then there are so many social limitations we have, and we cannot follow the same guideline for a 45-year Paris lady and same guideline for a 16-year-old kid. Okay, she was already so anxious to come to hospital with the diagnosis of big cyst in her abdomen which will in all probabilities require a surgical intervention, and then to you tell that I'll do a vaginal examination, it is very difficult for a patient to cooperate with you. And like the chances of something we picking up in vaginal examination are very meek, very minimal. So I think that was correct. I don't say that that was wrong. That patient came, abdominal examination if it was done, that's okay. And patient had come with a diagnosis, ultrasound was done. What was the finding in ultrasound?
So our ultrasound also, we did a TAS because she was a 16-year-old unmarried student.
Yes.
So in that also we saw a large cyst.
A large, around 16 centimeter
Yes,
cyst was there.
was reported.
Uterus we could not see, but that's normal, that's okay we thought, because if there is a big cyst with not that good resolution, with not that full bladder, uterus is small and maybe sunken in the pelvis or behind the cyst, okay. So those were the things, so we did not give any much attention to that finding, though next time we'll try to search the uterus and see. Then what happened after that?
Then we sent her for blood investigations, ma'am. Thing is, she got referred from outside only for lab cystectomy.
So
directly, she had that referral letter. But still, we wanted her evaluated.
So what, if you are sending blood investigation, what are the blood investigation you will send for?
So basic CBC we sent for
Yes.
her. With that, tumor markers we also
Yes.
sent. We sent
What tumor marker are important for this particular patient?
CA125.
CA125 we are doing in this patient to find out whether it is a tumor or for any other reason.
Endometriosis.
Endometriosis also. So do you know, Ananya, what kind of prediction this CA125 values will give us in this case?
It has a good sensitivity, ma'am, but specificity of CA125
that is
only
okay.
for endometriosis.
So tell me, we'll make it a little easy. What is the normal level of CA125?
30 less than
35. Okay, 35 is the cutoff. So I have not read it in any books, but this has been my experience that in cases of endometriosis, why I do CA125 not to diagnose or not to refute any diagnosis, but if CA125 in a case of endometriosis is more than 100, expect a lot of adhesions. Okay, even if you are planning a hysterectomy for fibroid endometriosis, if CA125 level cross 100, expect a lot of adhesions. Why CA125 actually rises?
It is a
glycoprotein
from the surface epithelium. Because of
so it is present lots and lots in that collected blood. Okay. So when the cyst ruptures, endometriotic cyst ruptures, the blood comes out and it gets absorbed by the peritoneum and the lymphatics. So when you test in blood, CA125 levels are. So if any cyst is confined, same thing is applicable for ovarian tumors also. If the thing is confined inside the cyst, CA125 levels will be low. So when the cyst fluid comes out, that means it is blood. It causes a lot of adhesions. Okay, that means some silent rupture has happened, or it is a disseminated kind of endometriosis in peritoneum also. Okay, so always remember, this has been a very important marker for me preoperatively. So if the CA125 level is more than 100, I counsel the patient and I remain prepared that this surgery is going to take more time, it is going to be a little more difficult. It has helped me a lot, and till now it has never proven me wrong, this kind of thing. Okay, so try it.
So her CA125 was reported as 142 now.
So 142, don't scare the patient that it is a tumor. It is still not a tumor. Okay, but you have to expect something wrong is going on. Okay, then.
And since she was a 16-year-old student with very anxious parents, we wanted her evaluated further.
Patients are anxious, not anxious. We have to do our tumor markers. If it comes negative, it's good. Okay, but if it is positive and you have missed it, you are doing a blood test. Okay, doing two investigation in today's world with so much medical legal issues are going on, I don't think it is wise to leave any stone unturned. Okay. Tell me.
So we also decided to get a CT scan done.
What are the other tumor markers?
We sent CA99, CEA, LDH, beta, HCG, everything was.
So only one tumor marker was high, that was CA125, and that was how much? 142. Okay. Then what other investigation? You will
So,
do?
ma'am, as you had advised, we also wanted to get a CT done for her, just to see CT abdomen pelvis was advised. And
so CT abdomen and pelvis. Now, why did we do CT? What I have learned is, and what is recommended also, any case of ovarian tumor, you must do a CT scan. Okay, it can surprise you with its diagnosis. It can tell you about the adhesions. It can tell you about the fat planes, and sometimes it can really come up with the diagnosis which will actually surprise you. Okay, so till then I was not thinking. I was thinking that I wanted to know, because she's a young girl, we should not injure anything. We should go in a planned manner, in a perfect plane, so that surgery is easy for her and uneventful and good for the patient. So I usually, before any young lady, if I'm doing cystectomy for endometriosis, I always do a CT scan, discuss with the radiologist what are the places where I can uh, enter nicely. This has really helped me handling big endometriotic cyst in young women. Okay, so this is advice also, that you must do it. So before any other investigation, blood investigation, before CT, you have to CT with contrast. When you are doing, you have to do one more investigation.
TSH.
Yeah, TSH. Okay, with CT with contrast, Ananya.
Kidney
Kidney
RFP
functions.
has to be.
Okay. What was the creatinine, Ananya?
So her creatinine was 1.2.
1.2. So when the creatinine was 1.2, the thing that came to my mind, that maybe some endometriosis is engulfing the ureter and maybe compromising the renal functions. Then it becomes even more important to do a CT scan and find out the relationship. Okay, so that you are more careful in that particular area during surgery. Okay. Then you did CT scan. You
So
want to
then
tell?
CT scan we did, and that's when all of us were taken by surprise, because when we opened the CT film, ma'am, we could see that there was a huge hematocolpus, and uterus was biconvate, ma'am, and left side kidney was also missing on CT.
Okay, so this was the finding. What was the finding? I'll repeat again. There was a huge, the thing which we were thinking as
Cyst.
endometriotic cyst with collection of endometriotic fluid. Actually, it was a
Hematocolpus.
huge hematocolpus with uterus on top of that, biconvate and normal ovaries, and one side ipsilateral absence of kidney. What is this?
So that's when we
What
came
is
to the
the-
diagnosis of OHVIRA syndrome, ma'am.
Can you tell about little bit about OHVIRA syndrome?
So it's OHVIRA syndrome is obstructed hemivagina with ipsilateral renal anomaly. This is a Mullerian.
How do you spell it? This is all, the mnemonic is
OHVIRA. OHVIRA.
very difficult for me to remember. Every time before saying it, I have to think twice that I am saying this correctly.
So that is obstructed hemivagina with ipsilateral renal anomaly. This is a Mullerian duct anomaly, ma'am. Very rare.
And complex.
Very
complex. Okay.
Because multi-cyst.
All others, actually, I don't know if you have read that article, and that even after people have started seeing this OHVIRA syndrome, the concept of Mullerian, how the genital tract develops, that only has come to a question.
Yes.
And people have proposed a new hypothesis. Before, we thought that two Mullerian ducts come, they join and make the uterus and upper part of vagina, and then sinovaginal bulb grows from below. So at the most, what can happen? There can be a transverse septum. But this is an oblique kind of septum. So this actually, the concept of this syndrome has put the age-old traditional, which you, me, all of us have learned the theory of Mullerian genesis, to a big question mark, whether what we have been studying and understanding is right or is it true. Okay.
So according to the new research that has come in, they say that vagina is in fact developing from the Wolffian or the mesonephric duct, and not even
Not
we
from
used
the
to divide
sinovaginal.
upper two-third, lower one-third. They've discarded that.
That entire vagina develops from the
Wolffian
duct.
Yes, ma'am.
And which article they must read if they want to go into
It's
the
an
detail?
article by ACN, ACIEN.
Okay, which journal it is published? You want to see it? You can show also which article. Very interesting article. Ananya has taken photocopies also.
So this is by Dr. Sunil K. Bajaj.
This is from Indian, published from Safdarjung Hospital. And they have, okay, that lady who has, that person who has come with this hypothesis, see how beautifully all of the PG should learn this habit. Okay, how beautifully she has learned, photocopied, and very nice. Because this case you might see in your entire career once or twice, and if you are seeing PG, during PG, you are lucky that you will not miss this kind of cases, and you will not get into problem. So what would have happened, Ananya? Then by chance, if we would not have done her CT scan, next day we would have taken her up for lap cystectomy. We would have been lucky if we would have been able to create pneumoperitoneum and then see what there is. Maybe that would have been the good thing. But without CT, if you are doing, sometimes what happens with the first stroke or a venous needle only, the cyst gets punctured. This big kind of cyst with a small abdomen, and it would have got drained, and then everything would have got collapsed. And then vagina and uterus are highly vascular organs. It would have started bleeding, and then what would have happened? Then we would have been in a mess. Okay, injury to, because vagina is so close to bladder. Like, we don't know. Like, it gives me little shivers to think that what all, if we would have posted thinking that she is having so much abdominal pain, we would have posted her as emergency in the night, then we would have got into real trouble. So always remember, Ananya, from this case, for ovarian tumor, any ovarian tumor, when especially in adults also, I say, please do one CT scan. 1,000, 2,000 rupees won't matter. 1,000 cases you will do correctly without CT, but where one case you would have helped 1,000 patients for money and going through CT, but one case where you get stuck, that will be a punishment for your life. Okay, so this case we came to know about this syndrome, that hematocholpos was there only by doing a CT scan. Okay, then what did you do? Now you know that this, all her pain and everything is because of her collected blood.
Yes.
Okay, and that's why she was not having specifically dysmenorrhea. Rather, she was presenting as continuous dilating pain and maybe urinary retention because of the compression of urethra. Okay, so is urinary retention common?
It can be common.
It can be one of the presenting symptoms. Okay. So after this, do you want to do examination now for this girl?
So
Till now we have not done, because endometriosis, even if we do, we are not going to. But now it is very important. We want to see how the vagina looks like. So what was the finding?
So we took her to OT, ma'am, and under anesthesia we put a speculum, and then we saw that bulge.
So bluish bulge was there of the obstructed heavy vagina. Okay. And what is the treatment then? Is it simple or is it difficult?
It's actually a simple treatment.
Very simple, very. If you diagnose it, the treatment is very, very simple. What is the treatment?
We have to do the septal resection.
Septal resection. Excision of the septum we have to do. Okay. And patient's symptoms will be relieved immediately. They will. So can you tell me, you were in the OT, can you tell me what was the finding?
So we had put her up, and on speculum we saw that lateral vaginal bulge, ma'am. So first we tried to drain the fluid from it. Was altered colored blood that was
and
coming.
foul smelling.
Very foul smelling, ma'am. And then we had to resect the septum. We resected, following which around 1.5 liter of altered blood came. And then we went till the origin of the septum and tried to remove it from there
As much as possible.
As much as possible.
Okay, so this was, and do you need any follow-up? Do you need to put a mold? All these things are not required. Okay, so this septum, if I can make sense of this, suppose this is the vagina. So the septum is neither transverse nor longitudinal. It is oblique. It comes from up and then it covers the lower part of the vagina. So it has all the properties of longitudinal vaginal septum. So just resection is enough. Rather, as compared to that, if it is a transverse vaginal septum, even if you resected the discoid part of this and you don't put a mold, what will happen? Fibrosis will happen and narrowing and constriction and stenosis will happen. So the good thing about it that it is a simple to treat problem. Diagnosis is the issue, and you can diagnose only once you have kept that thing in your mind. Okay, when mind does not know, then eyes can't see. Okay, okay, then tell me now, we'll discuss a little bit about the review of it. Patient is fine.
Patient is fine, ma'am.
Happy,
Discharged
also.
happy. All her pain, symptoms of urinary problems have subsided.
And she is very happy that we did not do any surgery for her,
Yes.
did not scar her abdomen.
Yes.
Okay. So let's discuss a little bit about Mullerian anomalies and a little bit about this particular syndrome.
Yes.
So usually what is the presentation? The presentation is different from other Mullerian abnormalities. Why? Because
one side
there is no one side function. She is draining from one side.
Yes.
So like other Mullerian abnormalities which present in this age group, usually they present with either
Amenorrhea.
primary amenorrhea or cryptomenorrhea, cyclical pain. All those two things will not be there because one vagina is nicely patent and the blood is draining out from there. Okay, so that's why it gets missed. Now, what can be the other symptoms? Because of pressure. So much pressure is
because of rectal pressure. She can complain of constipation.
Yes, and irritability also. Okay, episodes of loose motions and like it happens in a pelvic abscess. Okay, that kind of symptoms can happen. So patient can complain of
foul-smelling discharge.
Foul-smelling discharge. If there is a small opening there, patient can even complain of foul-smelling discharge. Yes. Any other presentation? So pressure symptoms and pain and bladder and rectal symptoms and vaginal discharge also patient can present. Any other interesting case? So there is one 2021 paper I was telling you that has been this syndrome is diagnosed in a newborn baby. Okay, and there is a big. They have put up the pictures also. A big cyst is hanging out of the vagina. Okay. So they did not know what it is. Then imaging was done and it was found that the patient is having OHVIRA syndrome. And when they nicked it, what came out? There was no blood because patient was not menstruating. So it was all mucus. You can go and find out this article. It was just published last year. It is in Journal of Pediatric Surgeries, some journal of pediatric surgery. So they just gave a nick and lot of mucus came out. Okay. So very young, before the sequelae happened, much younger they have picked it up. What can be sequelae?
So as for now, she's menstruating, she won't have complaints. When reproduction, when she comes to that?
One thing, it has already made a hematocolpos, pain and all those symptoms. If you do not, if the patient does not present.
Because of retrograde menstruation, she can have endometriosis.
Yes. She can also have, like with any other Mullerian abnormalities, this patient can again present with endometriosis, later coital difficulty and other things. Okay, but one thing we have to remember is endometriosis. That's why early treatment is important. Okay, so this was one of the very interesting cases I read. After history examination, I told you that we must do for every patient, but it is a lot of social concern that sometimes we think that, okay, young girl, when we know the diagnosis and we know when we are not thinking of Mullerian abnormalities, we are a little reluctant and little careful about vaginal exam because it becomes a big trauma for those young girls. Okay, but otherwise, if you do examination, if patient is cooperative, you might find some findings, bulge of the vagina. Sometimes when the patient comes with primary amenorrhea, we do it. Okay. But this patient was menstruating fish, so we never thought like that. One more thing, Ananya, there is, when I was an undergraduate student in PG, we were told that this was primary amenorrhea was one of the indications to do a per rectal examination.
Yes, ma'am.
So in today's world, do you think it is still holds good if a patient comes with? Have you done any young girl?
Not for young girls. They won't be cooperative.
And it is not good in our part also because first we are human beings, then we have to make a diagnosis. Okay, you have to be kind to your patient. You have to think like they are your family members. So I also am not in favor of doing a per rectal examination of a girl who comes with primary amenorrhea or cryptomenorrhea, because maybe that time we did not have such good availability of high level, high resolution imaging modalities, but today we have. So what examination, what investigation, if you are thinking of any Mullerian abnormality, which investigation you will suggest? Imaging.
MRI would be
very good. So for that, please remember, for this case we did CT scan because we were thinking of ovarian tumor. For Mullerian abnormalities, investigation of choice or imaging modality of choice is MRI, because MRI gives you good tissue differentiation. Actually, after this also, after this CT scan, patient requires a MRI. If we have time and resources, we must do an MRI to find out the exact. This was a simple, straightforward case, but we should do in any Mullerian abnormality. If you have done CT scan, if the diagnosis is not very clear, if you want to know the thickness of the septum, if you want to know the distance in the lower vagina, upper vagina, you must do an MRI, because CT scan will not give you that good information about all these findings, tissue differentiation. Okay, so MRI is the investigation of choice. Now, last question I'll ask you, then we'll finish this case discussion. Treatment. You have told how we treated. We did a speculum examination and resected the septum.
Yes.
Okay, that's it. So, if suppose, what is the best possible treatment we can offer to our patients?
So in today's time, because this is a young 16-year-old girl where vagina is not developed fully and there's hymen which is intact.
Yes.
So putting a speculum might injure the lateral vaginal wall, which can lead to post-op pain, longer recovery period. So what?
And there are social dilemmas also, in our culture where we maybe we have to think at least, okay. And the other thing, as you correctly said, it is not just about hymen, it is about the caliber of vagina also. It's not very easy to put a speculum and see exactly what is inside. So can we do something new?
So a better alternative is to put a vaginoscope, ma'am.
So we don't have a vaginoscope, the same hysteroscope.
Can be used.
Okay, hysteroscope can be used to close the introitus, and it is not, when girls are young, when hymen is intact, the chances of fluid leaking is not that high if you give moderate kind of pressure with the gauze pills or hand also is enough. Okay, so it is simpler to do a vaginoscopy with the help of a hysteroscope. Anybody has published this kind of data?
They have,
Okay. Do you want to tell about that?
So
this is a very interesting study about which Ananya is going to tell you. Actually, this is so good that all of you might know that Nature accepts very high-level articles, and this was a study done in Japan or Taiwan. Taiwan it was done, I think. The study comes from, this is the study which is published in Nature, okay, very high impact journal, and it is US. This is China and US. Okay, some authors are from China and some are from US, and they have published this very interesting paper. Do you want to tell something? Vaginoscopic
incision of oblique vaginal septum in adolescents, ma'am, with OHVIRA syndrome.
And how many girls they had?
They had around 14.
14 girls. Okay, 14 girls. So it was 14 girls did not come in 1 year, obviously.
Yes.
What was the time duration in which they found 14 OHVIRA syndrome?
In a 8-year period, ma'am.
8 year, they got 14 girls, and every girl, they have put a nice picture also that what kind of, how they use their vaginoscope. So there were, in 8 years, 14 girls, and all girls, they could successfully, without damaging the hymen, they could remove. You want to show this nice picture on the camera? Okay. So they could resect septum nicely, and all patients were followed up. So all were very happy, and so this is a new technique. I think if a patient comes to us, next time we should follow this.
So apart from the better visualization, post-op, after resecting the septum, they have also put a Foley's, 14 or 16 French distended Foley's for 2 days. They put in all
so that it doesn't get re-stabilized.
And less chance of stenosis. So this was different.
This is different. Okay. And like in our experience, usually resecting the septum, because this is not a transverse vaginal septum. So if you resect nicely, if you take a nice chunk and resect that out and cause good hemostasis, usually it is not required. Because in my 20 years of career, around 20 years of career, it's not that rare. Okay, one patient 2-3 months ago, we did cesarean. She was OHVIRA syndrome, and septum was resected, and she became pregnant after many years. And then we had done cesarean for her. That was 2-3 months ago. Now I'm having one patient who was in this very hospital 10 years ago. OHVIRA syndrome was diagnosed, and resection of septum was done. And now she's married, She wants to become pregnant, and she's coming. She also came 2-3 months ago. She's planning for pregnancy, so she wanted to know. So, how is the outcome? I have already told you.
Yes, yes.
It's a very good outcome.
Outcome is good.
Outcome
Just
is
that we have to think of preterm labor, other
okay.
causes
Yes.
that because
So
of the
that is-
septal insertion
yes.
of placenta.
Septal insertion of placenta can occur, and all those problems which can happen with uniconvate,
Uterus,
biconvate
yes,
uterus, implantation problems, abnormal lie. But usually fertility is not that big issue. Then you have to manage. You have to put a cervical stitch depending on the length of the cervix, all those things. But usually you don't have to scare them too much. Usually what we have seen that they have a good pregnancy outcome. Anything else you would like to
So,
tell?
like as you said, so many patients you've seen over here. So this is not as rare as we
Right.
think. So we
Yes.
should keep this at
Diagnosis
the
in
back of
mind. I think like 4 cases till now, including this one, I have seen. Not very common, but not that rare too. But the best thing I like about this syndrome is that it looks so scary, but the treatment is very simple and very good outcome.
Just family counseling we should
Yes.
keep in mind and tell them, explain the procedure.
It is very difficult for us to accept by the parents that patient has one kidney, and like it comes with a lot of stigma and lot of distress to parents. But once you explain, once you show the data, parents understand.
So this particular family had come in so much distress,
Distress,
thinking
yes.
that big ovarian
And
cyst.
big ovarian cyst, and they were counseled that after cyst also the chance of recurrence are very high.
Yes.
She will need GnRH analogs, then suppression of menstruation. Again, it can come, there can be fertility related issues. So patients were very happy. At least whatever is there now, that has been treated, and she will not require further treatment.
Yes.
Thank you, Ananya.
Thank
Thank
you
you
so
for
much,
such
sir.
nice
Thank
case
you.
discussion.